Hello and welcome everyone to the Therapy Insights Resource Roadmap Show, where we learn how to use the resources inside the Access Pass. If you're subscribed to our resource library, you have instant access to all of the resources that we're going to be talking about today. If you're not a member, you can get started today by heading to therapyinsights.com. If you're listening to this episode on a podcast or watching this video on YouTube and you want official CEU credit, head to therapyinsights.com and click on CEUs. Fill out the form for the PT Resource Roadmap Show, episode number 3, to get your certificate of completion. I'm your host, Shweta. We also have our Therapy Insights writers, Ross and Troy, with us today. Hey, everyone.
Hi. Yeah, hey, guys. Thanks for having us again.
Cool. So really quick, since this course is being offered for CEUs, we do need to verbalize our disclosures. All of us here are being paid by Therapy Insights to run this show. So let's get started. We have a great lineup of resources again this month, from Should I Get Meniscectomy, Minimizing the Concurrent Training Interference Effect, high intensity gait training after a neurologic condition, how to perform oculomotor examination, and what is heterotopic ossification. The first resource that we're going to dive into is high intensity gait training by Troy. Troy, since you wrote this piece, I'll let you talk about it a little bit. Tell us about this.
Yeah, absolutely. So this resource is really comes from from some recommendations that were made. And I don't know, I can't see it up on my screen, just to get that up. But yeah, it was.
Sorry, everybody. Let me get this going here. Then we can.
No worries.
I thought maybe I could leave my 2 displays up, but I can't. So here we go.
All right, perfect. Yeah. So it's really based on a CPG that came out, a clinical practice guideline that came out, I think in 2020. And really, this is meant to provide physical therapists with the ability to kind of quickly and accurately record gait training performance measures, as well as target heart rate zones for their patients with neurologic impairment. So a lot of this is really pretty basic stuff that you should have some exposure to already. But the nice thing about this sheet is the ones that I find that are the most helpful are the ones that I can grab and I can put right into my documentation and scan right in. So as I'm documenting in my own files, I'm saying, hey, refer back to to our scan sheet on our intake forms and subsequent plans of care and things like that. So what this is meant to do is get therapists on the right track when it comes to treating folks with gait impairments and neurologic conditions. So specifically in step 1, we talk about just determining ultimately max heart rate, which one of the kind of classic most known equations for that is just 220 minus your age is how we calculate max heart rate. And then we're looking for a specific aerobic threshold that we're going to prescribe as therapists. Ideally, that normally sits somewhere between 60 and 80% of max heart rate. So you take that 220 times the age or minus age, and then multiply that by either 0.6 or 0.8, and we'd run into our kind of target heart rate. Now, step 2 with this is, okay, a lot of our patients with neurologic conditions maybe have some complications or other comorbidities that are associated. So I think it's up to our discretion and our own clinical reasoning on what's maybe reasonable, where to start out within that range. And then how can we increase the intensity if we can't maybe increase their gait speed? So, right. So classically, if you're treating somebody that doesn't have a movement pathology or motor control deficits, we want to increase the intensity, we increase the speed, or we increase the incline. If that's not available, step 2 kind of gives you some ideas of ways that we can increase intensity and ways that other researchers have done in this clinical practice guideline in the past to work towards getting that target heart rate up a little bit higher and into that kind of aerobic threshold where we're seeing the most benefits for individuals. Step 3, right, is just recording performance. So 2 of the most classic and standard measures that are well documented for folks with neurologic conditions and others was a 6-minute walk test and a 10-meter walk test. So a 6-minute walk test, really trying to capture the client or the patient's ability to maybe ambulate in the community and to walk in the community. How far can they go? Maybe it's starting to touch into what's their endurance like. Is this 6 minutes? Might be challenging that a little bit. And then the 10-meter walk test, more of an assessment really of gait speed. So we'll measure that in meters per second. And you can use that to determine fall risk. Or right, ideally we're improving gait speed as time goes on through therapy. So use this, fill it out is what I have it envisioned as, and yeah, scan it into your documentation, come back, pull it back out with your patients. It's one of my favorite things to do whenever I'm doing a progress note, and I do a lot of progress notes because I see folks with chronic conditions. So I see folks for a long time often. And one of my favorite things is progress note day, when I can pull out all of my measures that we took on day 1 or on the last progress note and say, hey, look at this change, these changes that you've made, and really be able to get some buy-in from them, have them understand that their hard work is paying off, because sometimes, folks after stroke or after spinal cord injury or, other neurodegenerative conditions, they just live in the grind of the day to day. And it's helpful to look back. Hey, what were things like 2 months ago? What were things like 3 months ago, potentially, to see, oh, actually, yeah, we're doing good work here. So yeah, so that's my hope with this one. I hope you guys find it useful.
I was going to say, Troy, I actually have been using this principle in practice since I read your piece here for the last month or so. I have a gal with TBI who's had her TBI for about 15 years, and making any progress at all on a 6-minute walk test is hard with her. And I've been working with her for a long time, and I've been using this for about a month with her, and she improved a good 50 meters. I don't remember what the MCID or MDC is, but for her it was huge, So I was gonna say it really does work, and it is a pretty nice piece. Yeah,
I know, and actually, sort of as we move on to this next piece, maybe this is a good time to do it. It kind of talking about the article that supports some of this, right? So we have a little bit of a theme here in this resource, and then the next article that's coming up about high intensity gait training and and improving outcomes. And it's honestly, it's a little counterintuitive, right? I think as movement specialists, we're like, okay, hey, let's fix the technique and the mechanics, and let's avoid this circumduction, or all of these things that we learn in school, and then come to find out, guess what? Just getting some hard work done really pays dividends. So I'll talk about that. It's
motivating for the patient too. At least I found that as well.
Yeah, great.
My question to you, I mean, this is not particularly to you, Troy, but just like in general, just something that I'm throwing out there. Like, would you consider adding cognitive tests to step 2 at all?
That's a good question. I think if your goal, it depends on what your goals are, right? So I think you add cognitive tasks. I can't imagine, or I would be quite surprised if you're going to improve 10-meter walk test data or even 6-minute walk test data. Now, are you going to improve their ability to potentially participate in the community, go grocery shopping or something like that? Absolutely, right? I think that makes good sense, adding that cognitive task to the activity. I think makes it a little more functional, a little, take it out of a closed environment and put it more in an open environment, especially for somebody like Ross's patient that he mentions that has traumatic brain injury. Yeah, there's probably some deficits there. But if we're just looking about kind of improving gait speed and gait tolerance. I guess I can't say for sure, but it wouldn't be on the top of my list as opposed to just increasing things that are going to cost, energy. So.
Got you. Cool. Well, thank you for that nice one-page handout. And like you said, like most of your resources are very compact in terms of like how we can take that and fill it out in the clinic and send it to a physician, or how we can track progress. So I really love that about your resources. Just kind of wanted to tell you that.
Great, well, thanks.
We'll move on to the article that you were mentioning, which is related to this particular resource. It's the Improving Spatiotemporal Gait Asymmetry has limited functional benefit for individuals post-stroke. So I'll let you talk about it, Troy.
Yeah, great. So this is one of many articles, excuse me, that this original CPG that I was talking about has kind of looked at, and that APTA's Neurologic section would recommend for kind of literature review and reading. And really what it talks about is pretty much what we were just mentioning, this previous concept or maybe misnomer or misunderstanding of a lot of therapists is that we really look for symmetry, and we really are trying to improve mechanics with gait, especially after stroke. With someone with a hemiparetic gait, it's often, it's easy to see, it's easy to recognize, and it's something that often we go after right away. And I'm not saying that there's no value in that, but what this article really suggested is, I think they had maybe upwards of about 50 subjects. They put them in, or all the individuals after stroke. I believe they were more on the chronic stroke side as opposed to an acute stroke. So this is somebody 6 months post stroke, and so in an outpatient setting. And they looked at gait symmetry. They measured it really with a stride length or single step length, as well as stance time per limb. And they found that that when they did try to train these asymmetries, and what they did was they put them on 18 different sessions, and they on a split track treadmill that can help to modify gait and stance times, because the treadmill track is moving at different speeds. So they kind of normalized that to the patient, tried to train them in that environment, and then looked at these outcome measures after the fact. So they were really trying to measure or they were assessing changes in gait speed, in balance, in energy requirements, and overall activity levels outside of therapy. So they had activity monitors on them as well, and a variety of different outcome measures that assessed these pieces. And really they found pretty limited effect from those that had trained on gait asymmetries, or these different kind of spatiotemporal gait patterns, to improvements in their outcome measures that they were hoping. Now, so some trained gait asymmetries and some didn't. Now they did find, though, that guess what? A lot of people's 6-minute walk tests improved. So kind of getting back again to this other point of, hey, just getting the job done and working on gait in general and in getting the intensity up does show improvements. The other catch to that was they didn't notice that despite changes and improvements in 6-minute walk test for both groups, they didn't really notice that it altered their activity outside of therapy. So the next question would really be, and we have it on the bottom here, how much training and improvement need to occur before we affect the lives of our patients? So, right, there's often MCD data and MCID, so minimally clinically important difference and detectable change that we should be thinking about and paying attention to, because in this case, despite their significant improvements in some of their measures, they didn't actually, the subjects didn't actually participate in any more physical activity outside of the session. So, yeah.
Great. Thank you for sharing that.
Yeah, absolutely.
On to our next resource. Our next resource is a nice one-page handout on should I get a meniscectomy? Since this was put out by Ross, I will have Ross talk about it. Off to you, Ross.
Yeah, so with this piece, in our clinic, we see a lot of people who have meniscus tears, and a lot of them, a lot of people in the United States in general actually are treated with meniscectomy still. It's one of the most common orthopedic surgeries. There actually isn't great evidence to support meniscectomies. And so this is supposed to be kind of an educational handout that can be useful for somebody who has a meniscus tear, as something where they can really make an informed decision if they decide to go through with surgery. And so a lot of times in therapy, we get to see people with meniscus issues before they talk to a surgeon. And this is kind of a nice handout that you can give to them so that they can kind of make an informed decision with their healthcare. So it kind of outlines what the meniscus is, what a meniscectomy is, and then kind of goes through some of the evidence surrounding meniscectomies. So it talks about degenerative meniscus tears, which is what we see more commonly, typically in physical therapy. And it talks about how there was a pretty well-designed randomized controlled trial that found that exercise-based therapy was non-inferior compared to partial meniscectomy within the first 2 years or at 5-year follow-up. Most trials tend to incorporate some sort of strengthening exercises for the quad, hamstring, and hip muscles, as well as aerobic exercise. It talks a little bit about how the rate of meniscectomy has not really changed over the years. It's really stayed pretty constant, especially in the United States. One thing I touched on a little bit is a lot of times people think they have to get surgery to prevent osteoarthritis or to prevent further joint damage. And if anything, the research, depending on what study you read, it's either neutral or it favors exercise therapy. There was one study that actually found a 5 times higher rate of total knee replacement in people who had meniscectomies compared to people who did not. And I'd say anecdotally in PT, I see a lot of people who come in years after having a meniscectomy with pretty severe knee OA. And so I'd say that that's important for people to know as well. And then I get into kind of the different types of meniscus tears. So conventional wisdom has always been like, if it's a bucket handle tear or if there's a flap in the joint or something, those need to be treated surgically. Whereas if it's a more simple tear or something where you can have the hoop stresses that we like, and maybe then you won't need to have a meniscectomy. But it was interesting because there's some research where they've actually, like there's one survey-based study where they took almost 200 orthopedic surgeons and they presented them with these cases and they said, okay, which of these needs surgery, which needs exercise? And they tried to see how accurate they were. And they were about as accurate as a coin toss if you're going off of the imaging characteristics of the meniscus. So there's really, there's not really a good argument to be made there that certain types of tears should be treated with surgery quickly. So you can make the argument that maybe exercise should be the first choice for everybody for a while. And what's interesting is a lot of studies will actually say, oh, well, if it's a locked knee, we didn't include those people in the study because those ones obviously need surgery. And so I was thinking about it. It's like, really, well, what's our evidence for that? And I tried to find research actually looking at people who have locked knees to see, okay, do these people need meniscectomies? And I only found one study, but it was a well-done placebo-controlled trial where basically they took people with obstructive complaints or locked knees. Half of them got a placebo surgery, half of them got a real surgery, and there was no difference in outcomes between the groups. And so you might even be able to make the argument that even for people with locked knees, that maybe they could try exercise first. But one thing to keep in mind is that these, unfortunately, people with locked knees, whether they're treated conservatively or with surgery, they tend to have worse outcomes in general. And so it could be that perhaps some of these people are kind of depending on whether there's comorbid arthritis or something, they might be needing a different treatment altogether, like a total knee. And then I touched on traumatic meniscus tears. There's less research surrounding those, but from what I did find, repair might be the preferred treatment if it's a young patient or if it's in an area with good blood supply, so the periphery of the meniscus. Those can be repaired, and then there's a good argument to be made that maybe you avoid surgery altogether if it's not a good case for repair, even in traumatic cases. So yeah, that's pretty much that piece.
Ross, did you find anything related to like specific age groups as far as these studies were concerned?
Most of these studies were done in older individuals, just because older individuals tend to be the people who have the degenerative meniscus tears, and that's where really most of the research is done. But, and this isn't something I really got into with this piece, but there are a lot of asymptomatic meniscus tears. So it could be that even younger people have more meniscus tears than we think, and that they're just asymptomatic, and the knee doesn't start to hurt till later. And then that's when we start to pay attention to it more. But yeah, I'd say that most of this research is probably people aged like 50 to 70 or something like that.
Okay, I was curious as to whether, I mean, like, are they looking at age, and are they also looking at activity level of that person in terms of whether they're recommending surgery or not, or like
that was one, I believe, that survey-based study I was telling you about. I believe that the surgeons were also given that information as well. And then there's another trial that I'll talk about, and I think they may have gotten into age with that one too. I can't remember for sure, but I know that the one with the survey-based study, they had that information as well. They had imaging, locking characteristics, and tear characteristics, I believe, for that one. Yeah.
Okay.
Yeah, Ross, I really like this one. I think I feel like, I don't know, I get this question all the time, actually, and it's often one that's, somebody asking me at the gym, or like even outside of PT or family or whatever, right? Like, this is just one that comes up a lot for whatever reason. I really like how you lay out the evidence and allow people to kind of make an educated decision on what they want based on what your kind of findings have been through the literature. So I think this is an excellent one. Thanks for doing it.
Yeah, thank you. Yeah.
And then were there any in particular that talked about like prehab?
Not that I saw. Well, a lot of these studies, so one that I'll talk about, one of the studies that is one of the research article reviews that I did, it was an analysis of the ESCAPE trial. And in that study, they basically had people start with PT, and then they were trying to see which ones ended up needing surgery later. And so in a sense, I guess you could call that prehab. They're doing exercise with the hope that they don't need to have surgery, and then some of them end up going to surgery and some don't. But yeah, that's a good question as far as whether outcomes are improved with prehab versus not. That wasn't something I got into quite as much with this.
I mean, the reason I ask is because like even with prehab, and not just after like, something like a meniscectomy, but even like a total hip or a total knee, I feel like it has better outcomes, but it's not being, I mean, patients are not really being educated as much about prehab as they need to be, because there's like, I mean, I don't know what the evidence speaks to as far as that is concerned, because I haven't researched too much into that, but then I know that there have been people with like good outcomes compared to their counterparts when they've had prehab. I mean, activity does contribute to that up to an extent, but still like prehab is a big role.
Right. It seems like it'd be common sense that the prehab would be helpful, and I would definitely encourage patients, if they are going to go through with a meniscectomy, that they should do prehab. And in the back of my mind, I'd be thinking maybe you'll actually just feel better and not need the surgery, but it seems like it's common sense, but I didn't really look into the research on that, and it'd be interesting to do that. Yeah.
Cool. Well, since you were mentioning about the article that is tied to this particular resource, I will let you talk about that. So coming up is the article, In Patients eligible for meniscal surgery who first received physical therapy, multivariable prognostic models cannot predict who will eventually undergo surgery. And I'll let Ross talk about it.
Yeah, so this was the one I was mentioning. It was kind of piggybacked off of the ESCAPE trial. So it was, I think that most patients in that study started with exercise and some went on to have surgery. And so there was an expert panel of PTs and orthopedic surgeons. I think there was 10 to 20 of them. And they looked at different factors. So they looked at age, sex, Kellgren-Lawrence scores for osteoarthritis with x-rays, tear characteristics with MRI, and they looked at all these things and they said, okay, who are at the very beginning of the study, which of these patients is going to end up needing a meniscectomy? And essentially what they found, they did say that socioeconomic status was weakly associated. So people with a lower socioeconomic status were slightly more likely, I think, to end up with a meniscectomy. But it was such a weak association, they said they couldn't really say it was significant enough to even pay attention to it. And so their bottom line conclusion was there's no factor that anyone can identify at this point based on this study that can predict who's going to end up needing surgery versus not. And so it kind of just reinforces what I was saying at the last piece, where it's like, probably everybody should just try exercise therapy. And I tell most of my patients, it's like, at least 6 weeks, but preferably more like 8 to 12, because there's a good chance maybe you won't end up needing surgery for that. So, and then something else that was interesting is that this was one of the studies that just automatically excluded people with locked knees. And as we talked about before, it's like it seems like a lot of these research studies make that kind of assumption. It's like, oh, they've got a locked knee, they're a surgical candidate, exclude them. And maybe they don't really need to be doing that. Yeah, that was, I guess, the summary for that.
Again, like in this, did they consider age, activity,
Yep.
And did they mention anything about
BMI as well, I believe. Sorry, go ahead.
Awesome. I was just asking if they mentioned anything about, what kind of, what specific rehab did they go through, like their exercise? Or what else?
That's a good question. I would have to read the study again, since this was kind of a piggyback analysis of the ESCAPE trial. I didn't really get into what specific exercises were done. I can say that most studies I read where they do rehab for these sort of issues is pretty generic stuff. It's like cycling, walking, and then strengthening exercises, things like squats. Nothing incredibly fancy as most of these, but I came specifically to the ESCAPE trial. I'm not sure exactly what their protocol was. I do know that I think they were in twice a week it was either 6 or 8 weeks, something like that, of supervised therapy. And I think the sessions were about 30 minutes a session.
Yeah, I
don't have that in front of me, but I think that's what I remember anyway. Yeah.
I mean, I understand, but I personally feel that if they are a little more specific in terms of their inclusion criteria and the protocol that they use, then it might be a better predictor of, okay, how much did that influence their outcomes?
Yeah. Yeah, I think that makes sense. That maybe if you were more, and I guess that's partially what they're trying to determine, I guess, is what factors are associated, and really they couldn't find any in particular, and maybe future research will find something different. That's definitely possible. So
yeah, cool, thanks. We'll move on to our next resource. So our next resource is a one-page neat handout with some very nice columns, tabular columns, and this is about how to perform an oculomotor examination. And Troy is the one who wrote this resource. I will let Troy talk about it. Troy, can you tell us a little bit about this?
Yeah, absolutely. So, so this document is meant as a clinician resource, something to have with you, kind of by your side as you're going through an initial examination or you're getting ready to. for somebody that you expect some sort of oculomotor dysfunction. So yeah, like Shweta mentioned, we have a variety of tests that are kind of appropriate to be going through that are part of an oculomotor examination. How I instruct the patient on performance of that measure, and then based on the findings, kind of what potential associated pathologies might be likely. So really, we're looking at peripheral nerve lesions or central nerve lesions. So in general, my oculomotor examination, and I think most would include kind of the following things. So you're looking for spontaneous nystagmus. This is nystagmus, right? Is more or less movement, fast phase movement of the eyes. Spontaneous nystagmus is that's pretty significant. It's often something that you won't pick up in room light. So it is something where ideally you either have some oculography goggles or you have what are called Frenzel lenses, which are kind of like these clown house kind of lenses that don't allow your eyes to fixate, because naturally our eyes will fixate on anything. They're actually required to. We can't not fixate, and that can sometimes suppress this nystagmus that we see. But you're looking for just nystagmus at rest, depending on the look or on the direction and the severity of that. We can make some determinations about whether it's peripheral or central lesion. Visual field assessment, I think this is one that commonly people do, or at least they're maybe they don't actually measure, but they're at least aware of. So this is somebody that I think of, post-stroke is probably the most common thing. I think that people are like, oh yeah, they can't see out of their, they can't see to the left or something like that. So what this talks about is how I assess visual field. So I'm sitting right in front of them. I bring in from the periphery is my finger, using really myself and my own vision as a guide to when they can begin to see movement of my finger or come into vision. So I'm looking for visual field cuts. Normally those come on one side, most likely, right? That's that kind of classic CBA type symptom of somebody either with a posterior cerebellar or middle cerebellar artery occlusion or hemorrhage will have. But it talks about what happens if we have vision loss on both sides or of just one eye, and what those types of things can mean. Smooth pursuits is another thing that's vital. So what you're looking for here, this is the classic doctor's office test, right? You're going to point your pin or the tip of your finger. You do want them to focus on it. Find that often people will just stick their finger kind of straight up like this. You really want them to try to focus on the tip. So kind of pointing directly at them, either with a pen or your finger is most helpful. And then you're going to go through a standard H pattern. So that way we can really check all of the different nerves that are responsible for eye movement and the eye muscles. What I'm looking for is what's called saccadic intrusion, which means the inability to track that for a moment and then it catches up, or things like that. Saccadic intrusions are often associated with peripheral lesions, and then just the inability to track or inability to see, right? We might be looking at more of a central lesion. Gaze-evoked nystagmus. This is one that I do think is not as well understood or not as done as frequently, but gaze-evoked nystagmus is you're gonna have your patient or whoever you're testing move their eyes out to the edges of their vision. Now, I see a lot of people, a lot of students or other clinicians, they'll bring that point all the way out to the peripheries of their vision, and it's not uncommon to actually have some nystagmus at the very edge of your vision, even in a normal healthy person. So if you take them way out there to that edge, that's, you might give yourself a false positive. So you let them come back in just a little bit. And again, you're looking for persistent nystagmus, and you're looking for the direction of that nystagmus to kind of help guide you in terms of your diagnosis. Sometimes you'll see, someone with known central nervous system pathology, someone with TBI, if you take them way out on the edges of their vision, they'll just have non-fatiguing nystagmus that lasts for quite a long time. Vergence, this is a test where we're really just looking at abducens to see can they have the eyes converge. Findings on this suggest 15 centimeters you should be able to see without losing the ability to verge the eyes together. You'll find other outcome measures that want those numbers significantly lower than that. The VOMS comes to mind for somebody post-concussive or something like that, where we want those, down to maybe 2-3 centimeters away from the nose. So 15 seems like pretty substantial. Saccades. So saccades, this is another thing that I feel like isn't, if you don't do this a lot, you get the saccades and nystagmus confused, or I find that that's something that people struggle with. But saccades is the, I'll have my patient look at my nose and then look at my finger. So they're quickly shooting back and forth between looking at my nose quickly and looking at my finger quickly. You'll want to say finger, nose. So just like if you were doing a sensory assessment on somebody, you don't want to be really predictable because they can start to kind of accommodate to that. So you're looking for, is there a delay in the time that it takes for that to start? And most likely what you would see is an overshooting of one and then coming back. So if I have my finger out here on one side and I say finger and they look over here, they overshoot and come right back to it, I'm not too concerned. That's also not that abnormal. I guess there are folks without impairment that will do that. What you're really looking for is their eyes are fixated on your nose. You say finger, they overshoot their eyes, they overshoot on the way back, maybe they overshoot again and then they settle in. So it's this kind of zigzag closing in pattern on the fixed target. And then the last thing that I like to assess is pupillary light reflex. So this one, again, we're looking at what's the function of both the nerves that are responsible for sensing light and the motor response, right? You should see pupil dilation, pupil constriction, and both sides as you're doing that. But yeah, so these are the tests that I think kind of include or go into my standard oculomotor exam as I'm screening somebody maybe with dizziness that's going to come out of nowhere or something like that that's not positional. I'm going to go through all of these types of things to figure out if I think they need follow-up somewhere. So.
Well, Troy, I think this is pretty neat, and the way you've put in what are the findings with it and what could be the associated pathology in one page is a great reference. I was going to say that this, I know we're going to be talking about our case later on, but I feel in a way this is a good start to that case, because when you are in the initial stages of doing a vestibular examination and you're still kind of trying to differentiate and screen and narrow down as to what treatment you're going to go forward with this patient, the oculomotor examination is very important in those stages, the early stages before we really get into testing. So I think that this works out great as a reference to use in situations like that.
Yeah, no, absolutely. Right. So, and it doesn't go into, the specifics of, what does a central nervous system lesion mean, or what all are the pathologies that could include, right? Or same thing with a peripheral lesion, but it helps me to go through and be like, oh, wow, okay, this is funky. Right. Let me make sure that we're doing our due diligence and either getting you in for an MRI or back to primary care, or, oh, actually, this finding is normal for the fact that you have vestibular neuritis. And I don't need to be quite as concerned as I maybe was, or something like that. So hopefully you can find this as a helpful resource, and maybe even just a checklist as you're kind of going through oh, wait, yeah, I need to come back. And I want to check this other piece too as I'm working through my differentials here. So.
Absolutely. This is definitely something that I'm going to be able to take into the clinic right away. So
Yeah, great.
cool. Okay, we'll move on to our next resource. This is a 2-page handout on minimizing the concurrent training interference effect. And I'm going to let Ross talk about this piece. Ross, can you tell us a little bit more about this?
Yeah, so this was designed as more of a resource for clinicians, but some patients might also think that it's interesting. So it kind of goes through some of the evidence for the concurrent training effect and talks about how to minimize it as best as you can. So the concurrent training effect is essentially when you train for aerobic exercise and for strength and power adaptations, they have kind of competing effects, and power can be blunted by aerobic exercise in particular. And so this would be very relevant for either athletes looking to return to play or for older adults who are looking to enhance function and reduce risk of falling. It's not something I got into very much with this, but I've done other presentations, like when I was at PT school, things like that, talking about the importance of muscle power for fall risk reduction and for function. And it's actually much more, so power being your ability to exert force either with a light or heavy load quickly, whereas strength is your just force or slow speed force. And power is much more strongly correlated with functional activities like stair climbing, things like that. And so depending on your patient, it can be important to try to minimize this effect, but most people can benefit from both, not only for functional benefits, but also for health benefits. So this piece kind of outlines ways that you can still try to get the best of both worlds and hopefully minimize that concurrent training effect. And so this interference effect, if you're talking about muscle power specifically, it can occur, doesn't matter what your training status is. You could be trained, untrained, older, doesn't matter. If you're talking about muscle power, aerobic exercise can interfere with power development. If you're talking about strength, interestingly, it's more just highly trained athletes that have strength impaired by endurance training. But in PT, we care probably more about power anyway. So I think that anybody who needs to enhance muscle power could benefit from some of this knowledge. So it talks about same session training. So it talks about if you're the best is really to avoid doing your strength and aerobics in the same session. So when you're prescribing your home exercise program, if you can tell people to alternate days or something like that between doing their strength power work and their endurance work, you will have better adaptations with that. And then if you do need to perform them in the same session, it's better to do strength and power exercise first. Though it's still blunted. So there's two theories as to why there is this interference effect. One is just that the fatigue from aerobic exercise interferes with power development. There's probably some truth to that, but it's interesting. There was one study, and this was in rugby players, but they had one group do aerobic training right after they did their power training. One group did it 6 hours later, and one group did it 24 hours later. And the group that did their aerobic training right after power training still had blunted power adaptations. So it has to be at least partially explained by things going on at the molecular level, like signaling pathways and things like that. So let's see, I talked a little bit about, and one thing that I touched on that was kind of a sidebar, but it was a study that I thought was interesting is there was one trial, was looking at women with type 2 diabetes, and they were looking at health outcomes, so things like insulin sensitivity and fat mass reduction. And they actually found that for women with type 2 diabetes, separating the high intensity interval training and strength training in separate days actually had better fat mass reduction and insulin resistance adaptations compared to doing them both in the same session. So there's less research out there on that, but it's interesting that there's potentially even some health benefits to separating them out if you can. So I talk a little bit about duration and frequency. There's one meta-analysis, it was a little older, it was done in 2012, but they did a pretty good job of looking at the dose-response relationship, and they found that the interference effect was lowest if you had short training sessions, 20 to 30 minutes for low frequencies, less than 3 days per week. If you're looking for power to be your desired adaptation. There's some research looking at volume. There's one study where they, this is again athletes, but they took athletes and some of them did a ratio of 1-to-1 strength to endurance, and then one did 3-to-1, and then another did just strength. The group that did just strength training had the best power adaptations. The 3-to-1 ratio group also had impaired power adaptations, but the 1-to-1 group had the worst power adaptations. So even at a 3-to-1 ratio, you can still expect some blunting of power adaptations. And then it goes into intensity. There's some conflicting evidence with that. It looks like if you equate work, so you can do more work in a short period of time if you're doing high intensity exercise. But if you equate work, it doesn't seem to make a huge difference one way or another. If work is not equated, high intensity exercise, aerobic exercise might be more likely to interfere with power adaptations because you do more volume, which is associated with blunting the power development. And then modality, there's a lot of conflicting evidence. We don't really know. One of the newer meta-analyses that I read said that it doesn't really seem to matter what type of aerobic training you do. It all kind of interferes with the power development. So yeah, that was that piece.
So Ross, if I'm understanding this right, in terms of your takeaway, you're saying that like we wouldn't attempt so much of an aerobic training and power training like in the same session, right?
Yeah, so it might depend on your patient, but definitely if you're looking for optimal power development, and I'm not saying that you can't develop power at all with concurrent training, you can, but if you're trying to do it optimally, if you can separate out your trainings either onto alternate days or even waiting 6 hours, like that other study showed that even waiting 6 hours was a little bit better than doing them right together, that is better. And so in PT, sometimes we're limited because we have to address multiple things in one session. But when you're prescribing the home program, especially say you have a woman with osteoporosis and a recent history of falling, for that person, power is probably the adaptation other than balance training. That's the adaptation that you need. So for that person, I would be doing everything I could probably to try to minimize that. So I'd probably not be doing endurance training in session at all with that person unless they really needed it. It'd probably be more just the balance training and power training and maybe stuff for bone density. So yeah, so I'd say it depends on your patient, of course, but ideally, yeah, you want to separate it out, the aerobic and power sessions if you can.
Like even if we were to incorporate like power training into like most of the session, if we could do like aerobic training just for like maybe a warm up or a cool down, that could still work well. Right?
Yeah, and so aerobic, and that's a good point. So if you're talking a warm up, you know, sometimes we throw people on a bike for 5 minutes. That's one thing that was talked about, you know, with that meta-analysis, where it's like if you can do less than 20-30 minute sessions for a low frequency, you're less likely to have interference. And so I'd say that there's a difference between what we do, gentle cycling on the bike for most people isn't really aerobic, you know, like 5 minutes on the bike. I get a lot of people might be warming up their legs a little bit, but I'm sure their heart rate's probably not going over 60% max, or, you know, so it's like, I'd say that there is a difference between a warm up and true aerobic training as well. That's a good question. Yeah.
Cool. Thanks. Well, we'll move on to our next resource. This is what is heterotopic ossification, and this was written by Troy, so I'll let Troy talk about it.
Yeah, great. So heterotopic ossification. This is something that not a lot of people talk about, but can be really a big problem. It's so ultimately what it is it's abnormal bone growth that's often happening extracellular around joints most commonly. In terms of why this happens, they don't have actually that great of an understanding of it. But those that are at risk are often those that have had spinal cord injury or amputation, and are in general are younger individuals. So they, maybe you've acquired a spinal cord injury through some sort of traumatic means, and you have subsequent fractures or injuries along with that. These types of problems can go either undiagnosed or even diagnosed, but not with a lot of ability to kind of treat and manage. It's unfortunately not something that we can really get rid of necessarily. So managing it can be challenging, and it can often cause a lot of dysfunction for individuals. So limits often passive range of motion is what you would expect. You're going to see this on radiographs. In terms of treatment, right? There are some medications that can pretty much prevent or inhibit bone development and bone growth. However, you're also working with someone, like I said, often after a spinal cord injury that needs as much, that just by having that injury is almost guaranteed to be osteoporotic over the course of 12 months or maybe even less. So some of the dosing of those medications can be pretty challenging. What you see with it is often pain and swelling in the location wherever that's well after the injury occurred. So this like I said, it doesn't go away. So it might be somebody that has HO, is what it's often referred to as, much longer, years after a fracture or years after injury. Which can be tough. But like I said, radiographic CT scans, MRIs are used to identify this. It's graded on a scale between 1 and 4. So I'm talking about a more severe type of case. But you can have grade 1, which is just small pieces of bone. Grade 2 is pretty much getting larger and getting closer together in terms of that abnormal bone growth. What it looks like on imaging, I find is kind of more cloudy, more diffuse, looks like non-specific bone growth in an area. So this isn't necessarily, this isn't like an osteophyte or something like that that's forming just near the bone. This can be 6-8 centimeters away from the joint or from the area that was originally injured. So in terms of managing this, some gentle range of motion is appropriate, but you often don't want to push into, you don't want to cause an inflammatory response here. So if you're aggravating it, there's potential that you're going to be causing more problem, but working up to the extent of the range of motion that they have would also be important to make sure that you maintain that passive range that is available to them. I think that's pretty much it.
Troy, man, like in the treatments you've mentioned that there is like limited options available. I mean, there's nothing that can be like an invasive procedure to really,
I mean, honestly, no. It's embedded within the muscular tissue. So I mean, it would be, it's diffuse. It is not uniform, and it's not it's not like something that can be removed without just excising a ton of tissue, which would. The other catch is surgery is often one of the risk factors associated with this. So trauma is what will potentially set you up for this, and to go in and try to excise this would potentially just lead to worse impairment.
Got it. Okay, that's good. Thank you for sharing that.
Yeah.
As always, we try to wrap up our show with a case study. The case study for this month is, I'm going to try and talk about this in using the ICF model. So this was a patient of mine. it's a 50-year-old female with right posterior canal BPPV or benign paroxysmal positional vertigo. She lives with her spouse and 2 daughters, actually. And she works as a professor at a university. And she is very active for her age. She was wanting to further her education, was kind of going through her PhD process. And in the process of like working on her dissertation, spending a lot of time on her laptop, she ended up having neck pains, and she also had COVID. And post-COVID was when she started noticing more dizzy symptoms, being more off balance, and more neck pain. So she consulted like a lot of specialists in trying to really find an answer for what her situation was, and like trying to find some sort of treatment, but then she wasn't really very successful. So like with the frustration that was associated with talking to so many specialists and with going to so many appointments, trying to get her PhD done at the same time and teaching, it was a lot of pressure for her. And there was also a lot of anxiety that was setting in terms of like, why am I not finding an answer for my situation? And even though this patient was kind of educated, like she had a brother-in-law who was also a physical therapist, and talking to him and trying to figure out like, okay, how do her symptoms relate to possibly vertigo at that time, and she was not entirely diagnosed. And just her brother-in-law educating her about the maneuver and her getting into the positions and really feeling dizzy. Like it's very, very sensitive for these patients. They just don't want to be in that position. I personally have tried using the Dix-Hall Pike and even like Epley's on family members, and they just don't want to feel that feeling when they're really into the positions. So she just never really wanted to try therapy at all, just because of that anxiety. I mean, the anxiety that had set in from not getting an answer, and the anxiety that was associated with like getting into the position. So it was a lot to like even educate her and try like modification of maneuvers, and then get her solely accustomed to doing the whole maneuver. And it made a huge difference, and not just in like how like she went through the whole treatment, but also like how her anxiety symptoms kind of calmed down, to how her personality kind of like opened up a little bit more, and how she felt like all the stress had been relieved and things like that. So that was quite a life-changing experience, not just for her, but also for me as a therapist. So that's why I kind of wanted to talk a little bit about this case study. Coming to like BPPV in general, the resource that I used with this patient, which was the most basic one when we first started, was the Gait stabilization progression, where we're using the VOR exercises, which is basically your vestibulo-ocular reflex. Sorry. So the most basic ones are the VOR1 and the VOR2, where you have the patient hold their thumb, or sometimes they can even hold like a pen or a card, depending upon how much they're able to stabilize their gaze on something as narrow or something wider, and then gradually get comfortable and progress into something narrow. And the VOR1 is basically trying to rotate their head in the horizontal plane and still fixating their gaze on the thumb or the pen or the object that they're holding out. And VOR2 is basically trying to, again, fixate their gaze and trying to rotate their head from right to left. Sorry, I might be, so this is basically like a progression of the VOR1. And here you want to like not just do that in like horizontal, but also like in a vertical position movement, and where they're trying to like move the object and the head together and see if they're able to maintain that position. So the reason why I picked this resource was because, like I said, like early on, when you want to introduce something that's most basic with patients like these, for them to really get comfortable on gradually progressing to more intense activities, which might trigger their symptoms. It's easier to start with something minimal to at least get them to feel comfortable with their exercise program and maybe even want to try it, especially for someone who might have like really high anxiety like this patient had. We also have like a great course, which was actually like our very first Therapy Insights continuing education course by Helena Esmond, where she talks about strategies for decreasing visual vertigo in patients with visual motion sensitivity, post-concussion syndrome, PPPD. So yeah. The next resource, this was recommended by Ross, which was the Epley maneuver. I'll let Ross talk about it a little bit.
As a orthopedic PT, every once in a while we get vertigo and BPPV, but because it's not something that I'm seeing day in and day out, I like handouts like this as a reference for me. I'd say the Epley, especially for someone with right posterior canal BPPV, is typically what I try first. And if this patient became comfortable enough, and if she felt ready to try it, maybe after working on the gaze stabilization for a while, this would probably be what I tried first. And so this is a nice resource that Troy made where it kind of goes through the different positions and that you go through for right posterior canal BPPV. And it's also useful as a handout that you can send home with them. Sometimes patients do need to repeat this at home as part of a home program as well. And it's very straightforward and easy for anybody to figure out how to use it. And it's also, I was going to say the Epley maneuver, if I remember right, I've read that it's like over 3 treatments is like 80% effective, where it's like almost curative, you know, so it's like, if you can get them doing this, then that's great.
Yeah, absolutely. So the thing is, like, even with the maneuvers, like I said, like if we were to like completely relate it to this specific case, we need to talk about like not just what the patient is coming in with, but like if they have the associated neck pain as well, then we're trying to
doing
see
that.
Are we able to do modifications for this patient, like
and doing that screening that Troy had mentioned, you know, the other piece that Troy had, you know, where it's like if you can do some screening and make sure there's not a vertebral artery problem first, you know, if they have the neck pain with it. And so, you know, you definitely want to make sure that you really nailed in on your diagnosis and that the neck pain, you know, that they could take this as well if they had the range of motion to do it. That would also be critical before you went into it. That's a good point.
Right, absolutely. And Troy shared a resource for this case study as well. So Troy's resource was Cupulothiasis and the Semont Liberatory maneuver. So I'll let Troy talk about that.
Yeah, absolutely. And I'll chime in a little bit too on some of the other ones. I mean, thinking of this patient that does have kind of extreme anxiety that you mentioned. So one of the things that if I put somebody back in a Dix-Hall pike and right, the classic thing that we would expect to see here is right torsion, right, and an upbeating nystagmus. That would tell us, you know, okay, hey, this looks like a right-sided posterior canal BPPV. Honestly, I get super excited because, like Ross said, doing this stuff just gets people better so fast. And it's just one of those things where it's like people can come in really high level of impairment and they leave feeling a lot better. But you're right, they get anxious because guess what? When you put them back in that position, it was uncomfortable. And really, when I talk with my patients about this, I tell them, hey, the fact that this is uncomfortable gets me excited because guess what? That means that we're on the right track and you are going to feel so much better when you leave. So like, let's grit your teeth here for a little bit. This is going to be tough, you know, and this is going to be uncomfortable, but guess what? You are going to feel so much better. And I feel so confident that this treatment is going to be really effective for you. So I feel like that often kind of can give people the oomph to get back into some of these provocative positions, right? But we do all sorts of provocative tests as PTs, but this is definitely one that people don't often enjoy. So classic, right, would be the Epley maneuver. That's what we do in the United States. If you're in Europe, right? For the most part, they treat everybody. Instead of with an Epley, they do what's called a Semont or a Liberatory maneuver. Semont is the name of the person that kind of developed the test. But what this is you can use this for Cupulothiasis, which I mentioned in this. What we're talking about is a canalothiasis, meaning there's, those calcium carbonate crystals in one of those canals. In this case, you can treat BPPV canalothiasis with a Semont maneuver or a Cupulothiasis, which can also be uncomfortable for folks. That's right. If you put somebody in right side lying or in left side lying, they'll have apogeotropic nystagmus that's beating up towards the sky for a long period of time and it won't go away. What that means is that the cupula inside that canal is heavy. And because of that, it causes this nystagmus. What you do with this is honestly, it's kind of intense. You thought they were anxious before. It's kind of like this is a fast, high velocity, I don't want to call it a body slam, but it's intense. It used to really be taught as a body slam, and in fact, it would be, hey, pile up pillows on both sides. What we're finding more so now is it's actually the velocity of taking someone from one side position and trying to almost fling that otolith or whatever debris is attached to the cupula off of the cupula and continue on through the posterior canal and ultimately into the ampulla where we can kind of have our symptoms resolve. But you can treat folks with posterior canal BPPV with just this if you don't want to do an Epley. But I don't know that this one is any more comfortable or makes patients less apprehensive than the others. But you mentioned like 3PD for in terms of in that initial resource. That's another thing that I would be thinking about strongly with this patient specifically, just with the anxiety that's kind of set in. That's a little bit more classic of that, unless it's just this positional stuff that she's having anxiety with. But yeah, it's an awesome treatment though when it works, and you can really get people feeling good when they leave. So
oh yeah, absolutely. Well, I didn't try the Semont one with her, but I actually did the sideline test for BPPV, which is very similar to this maneuver, and also Brandauer exercises. They're also very similar to this, except that in Brandauer, you take them into the position, you wait for it to subside, and then bring them back up, just like how you would do in Epley. That actually worked out great for this particular patient.
oh, great.
Doing that, she felt that, okay, she was able to comfortably get into the sideline position versus if she were to do a whole Epley where she had to have even her neck in hyperextension, not supported. So I think like I said, like sometimes you might not get hardcore adjust the condition, but then we're working with other factors also. And like, especially anxiety, like psychologically, the impact that it has, it's hard. Because the first time that this patient showed up to me, like, and I tried to do a Dix-Hallpike testing with her, like she was in tears for a long time. So I had to like calm her down, and then she never ever wanted to get back into that. And then to the point where like, and this is again a patient who is like, like is pretty aware, is staying on top of things, is really trying to find those answers, has talked to a brother-in-law who is already a physical therapist and who has told her that, hey, this is pretty effective and things like that. And she has even seen that the brother-in-law like do the treatment for her husband. So in spite of that, it's hard because like I personally haven't had those symptoms, so it's hard to relate. But then you can empathize and understand that if they really don't want to get into that position, that is a lot. Like when losing your whole center of gravity and not knowing where you are in space is a lot for some people to take in. So it's about getting them comfortable. Like, okay, if this doesn't work for you, we have modified position. We have an alternate maneuver that we can try. Maybe that worked out great. And then a lot of education about like, okay, like how the patient is feeling after that, and slowly trying to get them comfortable that, okay, if you don't want to try this now, wait for a few more sessions. We'll try these exercises, which are like your VORs, the most basic exercises, and like try to get them comfortable with that, and then slowly transition. And she got to the point where she was able to tolerate a whole Epley. But it wasn't even about like, okay, like, I know, like, as far as these maneuvers are concerned, like, okay, if you say that you're able to do it 3 or 4 times in a visit, then definitely that makes them feel a lot better. But for someone who's like, okay, I did it once, but that's all I can tolerate for today, it has to be like approached slowly and, you know, build that relationship with them, and then kind of see if, okay, you're at that point where you can slowly introduce or have that conversation. And we start talking about possibly transitioning into like a full Epley maneuver instead of the modified one, and then get the patient comfortable with everything. So yeah. I think it was a good learning experience for me too. So
Yeah, well, sounds like it worked great.
cool. Well, that brings us to wrapping up today's show. So thanks so much everyone for hanging out with us. We'll be back next month with another Therapy Insights Resource Roadmap show. Thanks to all you therapists out there making therapy informative, empowering, and person-centered. If you do need, if you want to get instant access to these resources and hundreds more that we have on our website, please go to therapyinsights.com. All the links are available in the show notes. And if you have any questions about any of these resources, our roadmap show, just reach us out at support@therapyinsights.com. Be sure to vote for what we create next. Take care. See you next time.